Hello, this is Megan Brett, the hospital epidemiologist at UNMH, and I'm going to talk about COVID recovery. So let's jump in. What is COVID recovery? It's when patients are no longer considered infectious. So an infected individual typically can spread the virus by droplet, airborne, and contact routes of transmission. But when they're no longer considered infectious, they can no longer spread the infection by those routes. So what I'd like to do is take a step back and make sure that a few key concepts are understood before going into the nitty-gritty details of recovery and when people are considered not infectious. So I'd like to start off talking about the virus SARS-CoV-2 that causes COVID infection. Specifically, I'd like to talk about how we find whether it's present or not. So for example, we could look for its RNA, we could look for its proteins, or we could look for the whole blasted virus. So how do we go about doing that? In our lab at Tricor, we can look for its RNA by using the PCR or nucleic acid amplification tests. We can also look for proteins, and that's using antigen tests. And the key things to know is that these are the two tests that are routinely available. As much as it would be great to look for the entire virus, and we would typically do that by cell culture, that's not routinely available. That's only available in research labs. And so the challenge is that RNA and proteins are great, but they don't tell us about infectivity of the virus, and that's a key thing, is that only cultures really tell us whether the virus can infect other people's cells. So that's a shortcoming of some of the tests that we have available. Right, the other thing I wanted to show was what a typical timeline is for SARS-CoV-2 infection, or again, COVID infection. So you can see here a timeline. Here's weeks down here at the bottom, and patients can actually have virus in their upper respiratory tract before symptom onset, so that's considered pre-symptomatic. And I just want to show two elements of this particular chart. Is the fact that the red line represents viral culture, and you can see that that comes up and comes down pretty quickly. So that's virus isolation from the respiratory tract. Now, contrast that with PCR. So the blue line is a nasopharyngeal PCR, and the pink line is a bronchoalveolar lavage or sputum PCR. Those go up around the same time, but they take a much longer time to come down. So the challenge again is that the PCR is more sensitive, is what I would say. But again, it does not tell us about virus transmissibility, which is challenging when we're trying to figure out when people are no longer infectious. So now, what in the world do we use? And I'm just going to talk a little bit about the challenge with PCRs, is that a positive PCR may or may not indicate ongoing infection. It could represent dead virus or genetic remnants, and those can linger for up to 12 weeks. And about 20% of patients may have intermittent positive test results. It's really not easy to discern when somebody's been reinfected. And the last challenge is there's no current ability or immediate future plans for viral loads, meaning trying to figure out the amount of virus that's there in that sample, and that could tell you whether somebody has a more recent or a more distant infection potentially too. So again, a great test for diagnosis, not a great test for figuring out infectiousness or figuring out reinfection. All right, so let's look at some of the science, and I'm just going to highlight two papers that I think are particularly helpful. So this was from Germany and included about 14 patients, is my understanding. And here, I just want to show that this is the number of viral copies per swab, and this is the number of days from symptom onset. So you can see that as time marches on, that the PCRs are negative, but the flip side of it is that there are still some people with positive PCRs up to day 20 and even longer. The key thing, though, is that even with the positive PCRs, that they tried to culture these individuals and were not able to do so after day 8, at least in this cohort. This group did not include severely ill patients. So, to show you that, Here's another study that was done. And again, you can see that here's the number of virus copies based on genetic material. Here's the patient's duration of symptoms in days. And what you can see here is whether they were able to culture the virus or not. If it was negative, then it's an open circle, and if it's positive, it's a black square. So 95% of patients actually were not, did not have virus that grew in culture after day 15. You can see that there's a few patients on this side. So again, not beyond day 20. So that's why we've chosen 10 days for mild and more like up to 20 days for patients that are more severely ill. All right, so just to talk about trying to sort out when patients are no longer infectious, it's based on these studies. As you may remember, early in the pandemic, we used 2 negative tests separated by 24 hours. But since then, we've switched the time and symptom-based criteria, and this was updated by CDC in July 2020. And we updated our procedure at UNMH in September. I just showed you the studies, and if you wanted to do further reading, then the CDC has a great summary in the section titled Duration of Isolation and Precautions for Adults with COVID-19. Many studies to read there. I just highlighted 2 that I thought were most important. All right, so let's look at our recovery algorithm. And as you can tell, it involves both time and symptoms to judge when patients are safe to be removed from isolation. So again, for patients that are mildly or moderately ill, or even asymptomatic, it would be 10 days from symptom onset or from their initial positive test. At that time, you judge whether they're afebrile, and if their respiratory symptoms are improving. The answer is yes, then they're considered recovered and no longer infectious. And so it's okay to remove patients from isolation at that time. If patients are more severely ill, and the key thing here is it certainly includes immunocompromised, and here are the definitions down here. More severely ill to me means that people require higher support for oxygen. And so that would be high flow nasal cannula or greater, such as BiPAP or vented patients. And so for that group, you would rejudge at 20 days. You would look at clinical symptoms, whether they're afebrile, and if their respiratory symptoms are improving. And if the answer is yes, again, they would be considered recovered. So COVID recovery does not mean that all symptoms of COVID-19 infection are completely resolved. It just means, again, that they're improving. It also does not mean that all complications from COVID infection have necessarily occurred. You've probably seen patients, as I have too, coming in with things like strokes and pulmonary emboli as complications after COVID infection. And it certainly doesn't mean that their end organ damage from COVID-19 has improved. So for an example, our patients with ARDS who have the diffuse alveolar damage, that it may take a very long time for their oxygen demand to come down. All right. So when we determine that someone's recovered using that algorithm, what's the next step? It's to write recovery notes, just to do communication about when patients are no longer considered infectious. Why do we do this? I think it's to facilitate communication. Who can do this? There's the list there. So zinc teams for zinc patients, ICU teams, including nursing for ICU patients, trauma. And if there are questions or there are other services, then I'm happy to be involved and help with those notes. We're using notes for inpatients who have recovered from COVID-19 infection during the hospitalization, and working to try and teach people about the algorithm in order to not put readmitted patients in isolation who had previously positive COVID tests. I think it's one thing if they had a positive COVID test more recently, and it's another thing if they had it in March, and I'll go over that in just a minute. Where are these notes being placed? Under consult notes, under infection prevention, and there is a drop-down or a template to follow with drop-down menus in order to walk through all of the criteria to judge when someone's recovered. What else happens at that time? I would say it's okay to remove patients from isolation. And for more details, please refer to the COVID de-escalation guidelines on the COVID website. If questions arise or patients don't fit the algorithm or things are confusing, please don't hesitate to reach out to me on Tiger Connect. All right, the last thing I'm going to talk about is reinfection. I would say that there's few individuals, 5 total, that I've been able to find, but there may be more. The point is, it's not a great number worldwide. And these are individuals with current confirmed infections. No doubt there are probably patients that have not met that level of criteria, but at the same time, it appears to be a reasonably infrequent occurrence. So for a patient with COVID-19 infection, the blue shows when they're considered infectious. And again, everyone after day 20 is likely not infectious. And so a positive PCR in the interval of 20 to 90 days after symptom onset really would more likely represent dead virus, is that if you tried to put it in culture, it would not grow. There's some important exceptions. I would be a little bit more wary in patients who show up again with COVID symptoms like shortness of breath or worsening cough at the same time. That could represent things like pulmonary emboli or secondary bacterial pneumonias. So if you're having issues sorting that out, please don't hesitate to reach out to me, or infectious diseases certainly as well. And I think the take-home points here are that patients with COVID-19 infection are not infectious typically around 10 days, but up to 20 days in patients who are more severely ill. We've switched to use a time and symptom-based strategy for considering patients no longer infectious or recovered, and that's based on many studies and CDC guidance. And as you can tell, interpreting PCRs may pose some challenges, but thankfully things like reinfection appear to be reasonably rare at the moment, and hopefully even less frequent with vaccination. So thanks for letting me talk about recovery, and hope this was helpful.